Good morning, everyone. So, our today's lecture is on protein energy malnutrition part 5. In today's lecture, we will discuss about the management of protein energy malnutrition. In the last 4 lectures, we had discussed about the what is undernutrition, overnutrition, indicators of undernutrition, then what is protein energy malnutrition as by WHO and UNICEF, then the etiology of protein energy malnutrition, then the pathological changes in malnutrition in various organs and systems. Then we had discussed about the clinical manifestations of mild malnutrition, then moderate to severe malnutrition. In that, we have discussed marasmus, its clinical features, kwashiorkor, clinical features, then marasmic kwashiorkor. Then after that, we had discussed about the assessment of a severely malnourished child. Now, today we will discuss management. How will we manage moderate severe malnutrition? So let's start our topic part 5, management of protein energy malnutrition. So basically, as we have discussed that there is mild, moderate and severe malnutrition. So the mild and the moderate malnutrition, they makes the maximum portion of the malnourished children, and they are responsible for approximately more than 80% of the malnutrition associated deaths. What we are trying to say is that mild and moderate malnutrition, they are responsible for around 80% of the deaths. And it's obviously the greatest portion of the malnourished children. Now the mainstay of treatment is providing adequate amount of the proteins and the energy for at least 100 to 150 kilocalories per kg per day should be given. This is the main thing. This is the mainstay of the treatment of protein energy malnutrition, that appropriate amount of energy and amount of proteins should be provided, and at least 150 kilocalories per kg per day should be given. Then it is recognized that even a small increase in the protein requirement is sufficient for providing energy and for the rapid growth. A protein intake of 3 gram per kg per day is sufficient. Milk. Now, milk is the greatest source of providing protein. So, milk is a frequent source of protein which is used in the diet. Other sources include vegetable protein mixtures. They are also used very successfully. Then, adequate amount of the minerals and vitamins should be provided for the appropriate duration. Now, the best measure of the efficacy of the treatment of mild and moderate malnutrition is weight gain. Means how can we measure the efficacy of the treatment? And the best measure of the efficacy of the treatment provided is gain in the body weight of the baby is the best measure of the efficacy of the treatment. Now, the management of malnutrition, it depends upon the severity of the child. So children with severe malnutrition, they undergo various physiological changes to preserve essential processes, and these essential processes include reduction in the functional capacity of the organs and slowing down of the cellular activities. Now, the management, as we have said, that the management of malnutrition, it depends upon the severity. So mild malnutrition and moderate malnutrition, it can be managed in the ambulatory basis. They could be managed by a diet, proper diet, adequate amount of proteins, vitamins, minerals. But severe malnutrition, it can be only managed in the hospital. So children with severe malnutrition, they undergo some changes, some physiological changes. So some physiological changes occur in children with severe malnutrition, and these changes occur to preserve the essential process. Means the physiological changes which are coming in children with severe malnutrition, these changes are basically occurring to preserve the essential processes like reduction in the functional capacity of the organs and slowing of the cellular activities. Now these alterations, you changes आ रहे हैं, जो alterations हो रहे हैं, so these alterations and the coexisting infections, they put the malnourished children at a particular risk of death from hypoglycemia, hypothermia, electrolyte imbalance, heart failure, and untreated infection. Now what we are saying is that, so these alterations, these changes and the infections which are already present, they make the child, they make the malnourished child more prone to death. They put the children, malnourished children, at a greater risk of death due to hypoglycemia, hypothermia, electrolyte imbalance, heart failure, and untreated infection. So in general, there are 10 steps. So the general treatment, it involves 10 steps in two phases. The general treatment of PEM, it has 10 steps in two phases. Now these two phases are the initial phase and the rehabilitation phase. The initial phase or the stabilization phase. So the initial stabilization phase, it focus on the restoring homeostasis. The initial phase, it is focusing on the restoring the homeostasis. The homeostasis is the ability to maintain a internal state stable. So homeostasis, ability to maintain the stable internal state that persists despite of the changes in the outside environment. So the initial phase, it focuses on restoring homeostasis and treating the medical complications, and this phase takes around 2 to 7 days of inpatient treatment. Means the initial phase, the stabilization phase, it takes around 2 to 7 days of the inpatient treatment, and this phase, it focuses on the restoring homeostasis and treating medical complications. But the second phase, that is rehabilitation phase, it focuses on the rebuilding wasted tissues, and this phase takes several weeks. So the general treatment involves 10 steps in two phases. The first phase is stabilization phase, which is taking 2 to 7 days, and the next phase is rehabilitation phase. It is taking weeks, that is 2 to 6 weeks. So in the next line, there's a chart. It's a time frame for initiating and achieving the 10 steps. The first step is hypoglycemia. Step 2, hypothermia. Step 3, dehydration. Step 4, electrolytes. Step 5, infection. Step 6, micronutrients. Step 7, initiate feeding. Step 8, catch up growth. Step 9, sensory stimulation. Step 10, prepare for follow-up. So the chart is showing the time frame for initiating and achieving these 10 steps of the general treatment in two phases. So the time frame, here is the time frame for initiating these 10 steps and achieving these 10 steps. Stabilization phase, 1 to 2 days to 7 days to 2 to 7 days. Stabilization phase is taking 2 to 7 days, and rehabilitation phase, it is taking 2 to 6 weeks. So stabilization phase 2 to 7 days and rehabilitation phase 2 to 6 weeks. This is the time frame for initiating these steps and achieving these 10 steps of the general treatment. Now, 10 essential steps for management of severe acute malnutrition. Step 1. Treat, prevent hypoglycemia. Now here we are discussing the 10 essential steps in the general treatment of protein energy malnutrition or severe acute malnutrition. So first we are discussing step 1. Step 1 is treat or prevent hypoglycemia. Now, all the severely malnourished children, yeah, all the children with severe malnutrition, they are at risk of developing hypoglycemia. Now, when we are using this term hypoglycemia, we mean to say when the blood glucose level is less than 54 milligram per deciliter or 3 millimole per liter. That is hypoglycemia. So all the severely malnourished children, they are at risk of developing hypoglycemia. Therefore, the blood glucose level should be measured immediately during the admission. So when the child with severe malnutrition is admitted in the hospital, his blood glucose level should be immediately measured. But in case if blood glucose level cannot be measured, then the physician must assume hypoglycemia and treat accordingly. So, the initial step 1, that is step 1, treat or prevent hypoglycemia. So, we are saying that all the children with severe malnutrition, they are at increased risk of developing hypoglycemia. And hypoglycemia is when the blood glucose level is less than 54 milligram per deciliter. In case if the blood glucose level is not being measured or cannot be measured, then just assume that it is hypoglycemia and treat accordingly because जो भी बच्चा severe acute malnutrition के साथ आया है उसमें hypoglycemia होगा ही. So if we are not able to measure blood glucose in case, still we should assume that it is hypoglycemia and treat accordingly. Now, hypoglycemia could be asymptomatic or symptomatic. Hypoglycemia can be asymptomatic and symptomatic. Now, symptomatic hypoglycemia, it usually manifests as lethargic condition or unconsciousness, then seizures occurring, peripheral circulatory failure or hypothermia. So, symptomatic hypoglycemia, it presents with lethargic condition, unconsciousness, seizures or hypothermia. Now, treatment. Now for the treatment for the correction of asymptomatic hypoglycemia. Now we are treating first asymptomatic hypoglycemia. So for correction of asymptomatic hypoglycemia, just give 50 ml of the 10% glucose or sucrose solution. Now what we are saying? For correction of asymptomatic hypoglycemia, give 50 ml of 10% glucose or sucrose solution orally or by nasogastric tube followed by the first feed. Now this term 50 ml of 10% glucose or sucrose. This means 1 rounded teaspoon of the sugar in 3.5 tablespoon of the water. When we are using this term 50 ml of 10% glucose or sucrose, इसका मतलब है 1 rounded teaspoon of the sugar in 3.5 tablespoon of the water should be given orally or by nasogastric tube followed by the first feed. This was a correction of the asymptomatic hypoglycemia. For correction of the symptomatic hypoglycemia, we should give 5 ml per kg of the 10% dextrose intravenously. Now, this was a correction of asymptomatic and symptomatic. That is, it was a treatment of asymptomatic hypoglycemia and the symptomatic hypoglycemia. Now, the blood glucose level, it should be measured, it should be estimated every 30 minutes till the blood glucose level become normal and it gets stabilized. Means the physician or the nursing staff should measure the blood glucose level every 30 minutes Until when? Till the blood glucose level gets normal and then it stabilizes. Once the blood glucose level is stabilized, start the feed 2-hourly, every 2-hourly. Now, feed with starter F75 every 2-hourly, day and night. This means the feeding should be started when we are feeding the patient, when the baby. So the feeding should be started with starter F75. Now, F75 means formula 75. It is given by the WHO. It is a, or we say it F75 or formula 75. It is a WHO recommended starter diet. WHO ने recommend की है, ये एक starter diet है F75, एक starter diet है for severe acute malnutrition, which contains 75 kilocalories per 100 ml of the feed. So when we are using this sentence, feed with starter F75, so it is a formula 75. It is a diet. It is a WHO recommended diet. WHO ने recommend की है इसको, इस diet को, formula 75 को, as a starter diet. So it is a WHO recommended starter diet, especially for severe acute malnutrition. And this F75, it contains 75 kilocalorie per 100 ml of the feed, and it should be started as quickly as possible and should be continued 2 to 3 hourly, day and night. Every 2 hourly, day and night. So it should be started as quickly as possible and then continued every 2 hourly, day and night. This we had discussed. Symptomatic hypoglycemia. For correction of symptomatic hypoglycemia, give 10% dextrose IV. Feed with starter F75 every 2 hourly, day and night, and start appropriate antibiotics. Then we should estimate blood glucose level every 30 minutes till it gets normal and stabilize. Then in some cases, कुछ cases के अंदर या most of the cases के अंदर, symptomatic hypoglycemia, it can be prevented by frequent regular feeding, and the child should be fed regularly throughout night. So in most cases, symptomatic hypoglycemia can be prevented by frequent feeding the baby, frequent regular diet, and feeding the baby regularly throughout the night. Now, one more important point to remember is hypoglycemia, hypothermia, and infections. They usually occur as a triad. So this was our step 1, treatment and prevention of hypoglycemia. Prevent hypothermia, feed 2 hourly starting immediately, means the child should be fed regularly and frequently throughout the night, and prevent hypothermia. Hypothermia, hypoglycemia, and infection, they usually occur as a triad. Now, step 2. Now, step 2 is treatment and prevention of hypothermia. Step 1 was treat prevention of hypoglycemia. Step 2 is treatment prevention of hypothermia. Now, similarly, all the severely malnourished child or children, they are at risk of developing hypothermia due to impaired thermoregulation, due to improper thermoregulation, due to impairment of the thermoregulation, or low metabolic rate, or decreased thermal insulation from the body fat. So basically, all the severely malnourished children, they are at increased risk of developing, yeah, they are more prone to develop hypothermia due to impaired thermoregulation or lower metabolic rate. Now, children with marasmus, concurrent infections, denuded skin, and infants, they are at increased risk of developing hypothermia. Denuded skin is, it is the loss of the epidermis, which is caused by the exposure to any wound or any friction or any urine feces. So denuded skin is the loss of the epidermis. So children with marasmus, concurrent infections, denuded skin, and infants, they are at increased risk of developing hypothermia. Now, when we are saying hypothermia, this means hypothermia is diagnosed when the rectal temperature is less than 35.5 degree centigrade or 95.5 degree Fahrenheit, or axillary temperature is less than 35 degree centigrade or 95 degree Fahrenheit. Then we can diagnose hypothermia. So hypothermia is said to be hypothermia if the rectal temperature is less than 35.5 degree centigrade and the axillary temperature is less than 35 degree centigrade. Now, for measuring the temperature, we should use a low reading thermometer. Now, when we are saying low reading thermometer, means the thermometer which is having the range between 29 to 42 degree centigrade. So for measuring the temperature, the low reading thermometer should be used, especially for measuring the temperature in the malnourished children. A low reading thermometer should be used, and low reading thermometer means the range between 29 to 42 degree centigrade. Now again same case, if the thermometer does not register the temperature, if the temperature does not register on the normal thermometer, one should assume that it is hypothermia and treat accordingly. Similarly, we had discussed the same thing in hypoglycemia also, that if blood glucose level cannot be measured, one must assume hypoglycemia and treat accordingly. Similarly, if the temperature does not register on the thermometer, one should assume it as hypothermia and treat accordingly. Now, always measure blood glucose level and screen for the infections in the presence of hypothermia. Means, if there is hypothermia, the physician must do screening for the presence of any infections and should always measure the blood glucose level, because hypoglycemia, hypothermia and infections, they occur as a triad. That's why if there is hypothermia, we should always measure the blood glucose level and should do screening for the presence of any infections. Now treatment. So the child with hypothermia should be rewarmed. He should be rewarmed, providing heat using overhead warmers or radiant warmers or incubators or skin to skin contact or through convection, that is heat convectors. But rapid rewarming the baby should be avoided. Then clothe the child with warm clothes. Ensure that the head is also covered with the scarf or the cap. So then provide heat using the overhead warmers, skin to skin contact or heat convectors. Then the head should be covered, the head of the baby should be covered with the scarf or the cap. Then the baby should be placed in the warm environment, should be clothed well with warm clothes, and the baby should be covered using the warm blanket. Then the baby could be put in skin to skin contact with the mother, as in kangaroo mother care, to provide proper warmth. Now, beside all these measures, hypothermia can also be prevented by placing the child bed in the drought free area away from the doors and the windows, then minimizing the exposure after bathing or during clinical examinations, and keeping the child dry always. Avoid rapid rewarming as this could lead to disequilibrium. Feed the child immediately. Give appropriate antibiotics. Then, in most cases, hypothermia can be prevented by frequent feeding. That's why we are saying feed the child immediately and frequently. So, most cases of hypothermia can be prevented by frequent feeding. Therefore, the child must be given feeding immediately and subsequently every 2 hourly. every 2 hourly. Then similarly, in a hypothermic child, hypoglycemia must be measured. It should be looked for and should be managed also. Because we have said that hypoglycemia, hypothermia and infection, they occur as a triad. So in a hypothermic baby, hypoglycemia must be looked for and should be immediately managed. Then the temperature of the child should be monitored every 2 hours till it rises to more than 36.5 degree centigrade. What we have to do, the temperature should be measured every 2 hours till it rises to more than 36.5 degree centigrade. Then the monitoring of the temperature must be ensured, especially at the night when the environmental temperature falls. So temperature monitoring must be ensured, especially at the night when the ambient temperature falls down. Then prevention, place the child's bed in a drought-free area. Always keep the child well covered. Ensure head is also covered with the cap and the scarf. Place the child in contact with the mother's chest or abdomen. That is kangaroo mother care, kangaroo position, skin to skin contact. Feed the child every 2 hourly, starting immediately after the admission. Now, step 3. So this was step 2, treat, prevent hypothermia. Now step 3 is treat, prevent dehydration. Now dehydration tends to be overdiagnosed and its severity is overestimated in severely malnourished children. Now loss of elasticity of the skin may be due to loss of the subcutaneous fat as in marasmus or loss of the extracellular fluid in dehydration. Now dehydration, loss of skin elasticity, which is due to loss of the subcutaneous fat as in marasmus or loss of the extracellular fluid in dehydration. Now what happens in dehydration? The oral mucosa, it feels dry when we palpate the finger. So the oral mucosa feels dry to the palpating finger when gently rolled on the inner side of the cheek. So as soon as the physician will put his finger on the inner side of the cheek, he will feel the dryness. So the oral mucosa feels dry to the palpating finger. The finger feels the dryness in the oral mucosa. Then presence of thirst, hypothermia, weak pulse and oliguria are the other signs of the dehydration. Firstly, we are saying that the oral mucosa feels dry. Then there is presence of the thirst, excessive thirst, hypothermia, the pulse is weak and oliguria, low urine output. They are the signs of dehydration in severely malnourished child. Now it is very difficult. It is very difficult for the physician to estimate the status of the dehydration accurately in a severely malnourished child. What we are trying to say is that it is very impossible or it is very difficult for the physician or anyone to estimate the status of dehydration, accurate status of the dehydration in a severely malnourished child. Therefore, it is on the safer side or it is safe to assume that all patients with watery diarrhea have severe dehydration. In this, it is trying to say that it is very difficult to estimate the accurate status of dehydration in a severely malnourished child. So on the safer side, assume that all the severely malnourished children with watery diarrhea have some amount of dehydration. Low blood volume, that is hypovolemia, it can also coexist with the edema. This we had discussed in the Kwashiorkor. Now, the IAP, the Indian Academy of Pediatrics, it has also recommended the use of the one solution for all types of the diarrhea. Therefore, it has suggested ORS with potassium supplements in case of severe malnutrition. So basically treatment part mein dehydration should be corrected slowly over the period of 12 hours. We should correct dehydration very slowly over the period of 12 hours. In some cases, the dehydration can be corrected with the ORS. So use reduced osmolarity ORS with potassium supplements for rehydration and maintenance. This IAP has recommended. So dehydration should be corrected very slowly over the period of 12 hours, and dehydration can be corrected with the ORS. Amount depends upon how much the child wants, volume of stool loss, and whether the child is vomiting. So basically ORS is given orally or by nasogastric tube, initially 5 ml per kg every 30 minutes for the first 2 hours. So initially in the first 2 hours, ORS is given orally or by nasogastric tube. The amount is 5 ml per kg every 30 minutes for the first 2 hours. And after 2 hours, 5 to 10 ml ORS should be given 5 to 10 ml per kg every hour for the next 4 to 10 hours. The exact amount, it actually depends upon how much the child wants, the volume of the stool loss, and whether the child is vomiting. Initiate feeding within 2 to 3 hours of starting rehydration. Use formula 75 on alternate hours along with reduced osmolarity ORS. Be alert for the signs of overhydration. We should be alert that by giving all this treatment, the child is not presenting with signs of overhydration. We are treating dehydration and the child is presenting with signs of overhydration. So we have to make sure that there are no signs of overhydration. Then breastfeeding should be continued during the rehydration phase. The breastfeeding should be continued. And now prevention. Give reduced osmolarity ORS 5 to 10 ml per kg after each watery stool to replace the stool loss. So the frequent passage of the small stool, it should not be confused with profuse watery diarrhea, as it does not require fluid replacement. Here we have said now that give reduced osmolarity ORS after each watery stool. So we should not get confused with the frequent passage of the small stool with the profuse watery diarrhea, as that passage of the small stool does not require fluid replacement. If breastfeed, continue breastfeeding, then the refeeding must be initiated with F75 within 2 to 3 hours of starting rehydration. Now the progress of the rehydration should be monitored. The progress of the rehydration should be monitored every half an hour for the first 2 hours and then hourly for the next 4 to 10 hours. Then the pulse rate, respiratory rate, oral mucosa, frequency of the urine, volume, and frequency of the stool, frequency of the vomiting, it should also be monitored. So pulse rate, respiratory rate, amount of the urine passed, volume of the urine passed, volume of the stool, frequency of the stool, and vomiting, it should be monitored. And yes, one more thing, we should be alert for the signs of overhydration. अब overhydration के signs क्या हो सकते हैं? Increase in the respiratory rate by 5 per minute, or increase in the pulse rate, increase in the edema. Now, step 4. Step 4 is correct electrolyte imbalance. In step 3, we had discussed treat prevention dehydration. Now, step 4, correction of the electrolyte imbalance. Now, in severely malnourished children, excessive body sodium exists. In severely malnourished children, excessive body sodium exists even though the plasma sodium is low. Even though the plasma sodium is low, still there is excessive body sodium due in a severely malnourished children. Sodium intake should be restricted to prevent sodium overload and water retention during the initial phase of the treatment. Excess sodium in the diet may precipitate congestive cardiac failure. Now step 4 is correction electrolyte imbalance. Electrolyte imbalance को ठीक करना है हमको. So in a severely malnourished child, there is excessive of body sodium, even though the plasma sodium level is low. So what we have to do, we should restrict the intake of the sodium to prevent overload sodium and water retention during the initial phase of the treatment. If there is excessive sodium in the diet, it would precipitate congestive cardiac failure. Now, all the severely malnourished children, they have deficiency of potassium and magnesium, which may take 2 weeks or more to get correct. Means all the malnourished children, they have excess sodium, but all the severely malnourished children, they have deficiency of the potassium and the magnesium, and it takes around 2 to 3 weeks to correct them. Severely malnourished children, they can also develop hypokalemia and manifest with weakness of the abdomen, skeleton, and even respiratory muscles. This may mimic flaccid paralysis because there is weakness of the skeletal muscles, abdominal muscles, respiratory muscles. So this may look like flaccid paralysis. This happens in children with severe malnutrition because they develop severe hypokalemia and then they manifest with weakness of the abdominal, skeletal and respiratory muscles, which looks like flaccid paralysis. Give supplemental potassium at 3 to 4 MEQ per kg per day for at least 2 weeks. This is the treatment. So give supplemental potassium 3 to 4 MEQ per kg per day for at least 2 weeks. On day 1, give 50% of magnesium sulfate 1 m once. Then after that, give extra magnesium, that is 0.2 to 1.2 MEQ per kg daily. Excess body sodium exists even though the plasma sodium is low, and so decrease salt in the diet. Then multiple infections are common, so assume them as serious infections and treat accordingly. Similarly, assume them as serious infections and treat accordingly because multiple infections are common, and the usual signs of infection are fever, such as fever, but it is not present. We are saying that multiple infections are common and we should assume these infections as serious and treat accordingly. And the most common sign of infection is fever, and that is absent. Then hypoglycemia and hypothermia, they are the indicators of the severe infection because we had discussed that hypothermia, hypoglycemia and infection, they occur as a triad. Thank you. In the next lecture, we will continue with step 5 to 10. Till then, thank you.